Hello, my name is Gerry McElvaney. I'm the Professor of Medicine in RCSI, and it's a great pleasure for me to accept the Health Research Board Impact Award for 2021. My research career began really in UCD as a student in the Mater Hospital from 1976 to 1982. And I graduated from UCD in 1982. I then did my general internal medicine training in Dublin. I realised, however, that to do specialist training I had to go abroad, and I went from Dublin to Vancouver in 1986 and did a pulmonary fellowship there. I really enjoyed my time in Vancouver, but the pulmonary fellowship at that time put a lot of emphasis on physiology, and I thought that the future of research in pulmonary medicine really would centre on cell and molecular biology. And because of that, I went to work in the United States in the National Institutes of Health in Bethesda, Maryland. And there I started to work on inflammatory lung diseases, in particular on genetic inflammatory diseases, such as cystic fibrosis and alpha-1 antitrypsin deficiency. We realized at that time that although these conditions were relatively rare, they served as very useful paradigms for more common conditions. So for alpha-1 antitrypsin deficiency emphysema, we could extrapolate to more common non-hereditary emphysema, and the same for cystic fibrosis to more common forms of inflamed airways. So I worked in NIH and then in Cornell for a number of years and came back to Ireland in 1997. And I was appointed Professor of Medicine in RCSI in 1997. And since that time, I've been working here in Beaumont Hospital and particularly in the Smurfit building, doing research in inflammatory lung diseases, particularly those with a genetic component. So I'll talk to you about my work in alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency is an excellent example of translational medicine. So what happened here was in 1962, two doctors, Laurel and Erickson, noted that on serum protein electrophoresis, some patients had a missing alpha-1 band. And they went back to those patients and found that 3 of the 5 patients had very severe lung abnormalities, specifically emphysema, even though they did not smoke. And they found that this protein was a serine protease inhibitor. And although they called it alpha-1 antitrypsin, they discovered, or other people discovered, that the main target of this protein was neutrophil elastase. It inhibited neutrophil elastase in the lung. And this gave us the protease, antiprotease theory of emphysema. So basically, what they were saying was, if you had a deficiency of alpha-1 antitrypsin in the lung, the neutrophil elastase had an unopposed proteolytic action. And that in cigarette smokers, even those without an actual deficiency of alpha-1, cigarette smoke would oxidize the alpha-1 antitrypsin in the lung, rendering it functionally inactive. Again, leading to a protease action in the lung, an unopposed protease action in the lung. For many years, myself and others worked on trying to understand the pathogenesis of emphysema in alpha-1 antitrypsin deficiency and extrapolate from that to common emphysema. And we developed a therapy for alpha-1 antitrypsin deficiency lung disease, whereby we helped purify alpha-1 from the blood of so-called healthy or MM individuals, and we infused it into the veins of people with alpha-1 antitrypsin deficiency. And we showed that you could increase the levels of alpha-1 antitrypsin in blood and also in lung. And this alpha-1 was active against neutrophil elastase. And that was the first real COPD-specific therapy developed in the last 50 to 100 years. Following that, I came home in 1987. And there are a few things that struck me. Alpha-1 was under-recognized and misdiagnosed, not just in Ireland, but throughout the world. The US studies showed that it could take 5 doctors up to 7 years to make a diagnosis. Now, we realize that environmental risk factors for alpha-1, for COPD, are well known, but alpha-1 antitrypsin deficiency is the only known genetic risk factor for COPD. And we thought it was really important to get a grip on that in this country. For example, there had been a paper in 1993 which suggested that around 250 Irish citizens had severe alpha-1 antitrypsin deficiency. We thought this was a significant undercalculation. So the first thing we did was we got access to the Biobank DNA collection at Trinity College. This is a tremendous resource. So you have an anonymized database, collects data on age, gender, educational status, and county of birth for 1,100 individuals from mouth swabs. And we looked for Z and S variants of the alpha-1 antitrypsin gene. And we were surprised because there's far more alpha-1 antitrypsin deficiency than we would have thought. We found that 1 in 25 Irish people carry a Z gene. And that was a really major change in our way of thinking. And we looked at it further. We looked at the prevalence of alpha-1 antitrypsin on the island of Ireland. We found that there's approximately 3,000 Z individuals with a carrier rate of 1 in 25, an estimated 12,000 SCs, and over 250,000 MZs. So the number of ZZ individuals, severe deficiency of alpha-1 in Ireland, was 8 times more numerous than previously thought. We then decided we would make this condition more well known. We set up an alpha-1 foundation in Ireland. We set up a website, set up a Facebook page, and following that we also produced a lot of information guides and leaflets for patients and healthcare professionals. We were greatly helped by our colleagues in the US Alpha-1 Foundation, who helped us in our initial startup. And we also set up a targeted detection program. So the targeted detection program was interesting. Following a series of meetings in the World Health Organization and following some statements by the ATS and the ERS, it was determined that we should consider doing targeted detection for alpha-1 antitrypsin deficiency. And we were the first country in the world to have a national alpha-1 antitrypsin deficiency targeted detection program. This was financed by the HSE, and we tested all COPD patients, all non-responsive asthmatics, all people with cryptogenic cirrhosis, all first-degree relatives of patients or carriers with alpha-1 antitrypsin deficiency. And this is all done free of charge, and anyone who was found to have a deficiency allele was then offered a chance to come to our clinics in Beaumont Hospital. The roots of COPD are in your family tree, no doubt whatsoever about that. Now we started to build up not only awareness, but a large patient population to see if we could better understand alpha-1 antitrypsin deficiency, not just in the Irish context, but throughout the world. So we screened over 20,000 patients to date. At least 30% possess at least one abnormal alpha-1 gene. We've discovered nearly 400 ZZs and a similar number of SC individuals and over 3,700 MZ individuals. This is one of the largest alpha-1 clinics in the world. And we've done studies to help our patients. So we were the lead center in the RAPID study, in which ZZ individuals were given plasma purified alpha-1 antitrypsin once weekly or placebo over a 2-year period. And we found that intravenous alpha-1 antitrypsin therapy led to a 33% reduction in lung density as measured by CT scan over a 2-year period. And then at the end of the 2 years, those in placebo were switched to medication, to alpha-1 antitrypsin medication, and again was a decreased decline in lung tissue density. This is the first time ever that a medication was shown to impact positively on progression of emphysema. It was a breakthrough, but you'll notice that it didn't completely stop the loss of lung tissue in these patients. We've learned a lot over the last number of years, usually with the help of our patient populations. So we know now that alpha-1 antitrypsin deficiency is common. 1 in 25 people carry a Z gene. We know from our research that people with the ZZ form of alpha-1 get emphysema even if they don't smoke. We know that MZs, now remember there are 250,000 MZs in Ireland, have a 10-fold increased risk for COPD if they smoke. We know that SCs have an increased risk for COPD if they smoke. But interestingly, MZs and SCs have no increased risk if they don't smoke. This has led us to really concentrate greatly on smoking cessation in this population. And perhaps one of the more important things we've discovered is that alpha-1 antitrypsin deficiency is not just a protease-antiprotease imbalance, it's an inflammatory disorder. Alpha-1 has a myriad of anti-inflammatory effects. You can see in the graph on the right. It's a massively important anti-inflammatory, and when you lack alpha-1 or the alpha-1 antitrypsin is inactivated, you're prone to inflammatory lung disease. There are big unanswered questions in this area. Is alpha-1 antitrypsin deficiency emphysema the same as common emphysema? Is the COPD seen in smoking MZs and SCs the same as that smoking in people without alpha-1 antitrypsin deficiency? How much alpha-1 do you need to protect your lungs, your body? We've had big lessons here from COVID. We know that in COVID infection, the normal response is to really massively increase the amount of alpha-1 antitrypsin in the blood and in the lungs to protect those organs. And we need to understand better the pathways of emphysema to see what new therapies we can discover or what old therapies we can improve. So we plan to evaluate our patient population very effectively over the next number of years. We will look at ever smoking and never smoking ZZ, MZ, SC and MN individuals. We will use state-of-the-art CT scan evaluations, pulmonary function evaluations. We'll measure quality of life, activity, and we look at inflammatory biomarkers, which we have developed in our own lab. We will evaluate bronchoalveolar lavage and lung cells. We look at what controls secretion of alpha-1 antitrypsin in response to inflammation or infection. And we have a great opportunity to compare our results to other large databases, such as the European Alpha-1 Registry and the NIH Alpha-1 Antitrypsin Deficiency Biomarkers Consortium. We think that by performing effective research in these populations, we will make great inroads into understanding not only alpha-1 antitrypsin deficiency emphysema, but non-hereditary emphysema. We'll improve the therapeutic options available to us, and we'll make a real impact in patients' lives. These are the people that helped me in that task. I'd like to end there by thanking you all very much for your participation. And again, I'd like to thank the HRB for giving me that award, which I think will help us greatly in performing what we need to do in this area.